Do you have any burning questions from the audience? If not, I'm going to jump in. So many thanks for your presentation. It's really exciting, and clearly our ability to analyze big data is changing beyond recognition. One question I have for you is, over the next 3 years, we're going to have a lot more data as we do longitudinal scans and access to other data sets. What would be your wish list over the next 3 years? What should we measure which we're currently not measuring? So I'll start with Pearse.
So my wish list actually is not about what we are measuring or not. My wish list is something bigger than that, which is that I think that the UK can be a world leader in AI-enabled healthcare, but I think to achieve that, we need to have much better linkage between data in the NHS and data in the universities. And in my experience and my opinion, if you're a UK university affiliated with University Hospital, you should have relatively seamless access to the data in the hospital. And I think we're very far away from that at the moment.
Yeah, no, I mean, we have similar kind of thinking ourselves around matching UK Biobank data with registry data for patient cohorts with cardiomyopathy or with other diseases. I think Biobank in a way has offered lots of nice approaches for kind of standardization and harmonization that actually could be very helpful for trying to integrate data from the NHS and from primary care. But you're right. I mean, I think it's in many ways it's generalizing it to the data sets and the people who are going to benefit most from the discoveries. So how we broaden the pull through outside Biobank into patient populations.
Thank you. Yes, sir.
I mean, I'd certainly be second the comment about NHS data and making that linkage is really crucial in terms of understanding trajectory of disease. I guess the other thing I would say is, we're very clear now in terms of neurodegeneration, the impact of risk factors. So I think more data about some of those within the population would be massively useful. And then I think fluid biomarkers, plasma particularly, there's a real opportunity there in terms of, again, being able to identify, track disease and important assays.
Thank you very much. Do we have any questions? Yeah, please.
Hi there. Thank you. One question I had, which is regarding, it's Rajashi Banerjee from Oxford and Perspective. One question I had about getting data linkage to primary care and to patients. As patients come back into Biobank for future imaging, which they're already doing, is there scope to consent them to give their primary care record? The reason I'm asking this is I think there's often institutional questions as to who owns the data, how do we do that? With UK Biobank, it's pretty explicit. UK Biobank owns the data that patients have been graceful enough to give to you. Likewise, I think in primary care, if patients say, I want data to go to UK Biobank, I don't think any primary care provider or health network is going to get in their way.
So I mean, we're working very closely with NHS England, with RCGP and the BMA Joint IT Committee to get to the point where the consent of the participants to get linkage to not only the hospital data but the primary care data can be achieved. I think Vanessa's presentation on the number of people who had a diagnosis of dementia, that was because that was based on the HES data, the hospital data. We know from other studies that the primary care data will pick up very much larger numbers of people who have dementia or other neurodegenerative conditions, and it will do it much earlier. So I think the move to the UK Biobank data being only available on the platform, a secure platform hosted within the UK, and researchers working on the data on that platform, I hope will help to get an agreement to have the primary care data incorporated in the UK Biobank. We've gone through a long process with NHS England about the checking of our consent, its validity, its currency, the security of our data system, and essentially our research analysis platform is a secure data environment. And so although it's a nice idea that each of the 500,000 participants say to their GP, please give the data to UK Biobank, I think that's not scalable. I think one has to recognize that the GPs are the data controller for the primary care data, and understandably, not only are they busy, but they are concerned about their liability if they make data available, even with consent. And so the announcement by Wes Streeting back in October that he was minded to issue a data provision notice, a direction for the data to be made available to consented studies like UK Biobank, if they went through all those kind of checks, I think was a big step forward. We're hopeful that we can get there. The transformation of the data would be huge in terms of the amount of information we would have on the participants' health, the earlier diagnosis of disease, and I think it's very important to understand that that direction would essentially move the liability from the GP to the NHS, and hopefully do so in a way that does not involve a lot of work for GPs. But it's a long process. I hope that we're near to the point where we can address all of the concerns and make those data available.
Many thanks. I think we have time for one more question. Mark, you had a question.
Hi, Mark Collier, British Medical Association General Practice Committee, co-chair of the Joint GPIT Committee. Yes, the data is complex, but work is going on. My question is on the ability to predict, like, for example, dementia. It's still a prediction, isn't it, the increased risk factors. How do you ascertain the good that might come from it and the harm that might come from it by suggesting to people early on that they might be starting to develop a neurodegenerative disease before they have? And I'm asking that with my GP hat on, because I have those patients who come, those patients are the people I see in front of me. And it's with that GP hat on that I mentioned the use of data. We have to be so careful with the use of data, because if our patients lose their faith in us as being able to safeguard their data and the confidentiality that's inherent in that doctor-patient relationship, it will do harm for everybody. So any use of data, any sharing of data has to be done extremely carefully. If you look back over the last 10 years, there has been great progress in improving the safety and the security with secure data environments, rather than extracts being given to individual research institutions to store on their own servers, for example. So there has been improvement, but we have to be, if any new system comes into being, we need it to be the best it can be, so that we can continue to do our job, so that we have the faith of our patients, and they can trust us, and they can tell us things in complete confidence, knowing that we have their best interests at heart.
Shall I comment? I mean, I think, you brought up a really good point. It's balancing that risk and benefit, is it, overall? And as I said earlier, I do get a sense that patients are more open to hearing potential around risk earlier on. And there have been various studies that have looked at, if you share ApoE4 status, for instance, what's the impact, both from a qualitative point of view, but also in terms of what the person actually does with the information, and largely seems positive. But I think we need to do more. And I mean, it could be that the UK Biobank Brain Health Study, again, could do a nice piece of work in terms of understanding the qualitative impact and people's views on that once they've had that information collected at the visits, plus the linkage done. I mean, I think, as I said, I think generally people are wanting to understand their risk earlier. I think it's crucial how we communicate it, actually, and also recognise the impact. I remember some time ago I was at a meeting in Scotland, and somebody from Alzheimer's Scotland pointed to me that they had a lot of people contacting them saying they were very worried about genetic risk data, particularly, and if that was shared more widely, what would that mean in terms of their eligibility for insurance, particularly, for instance? I know that's a big concern in the US for obvious reasons that are different than here, but I do think we need to think about the wider impact of data being shared when you're talking about progressive diseases like dementia. But I think it's about having more discussions with individuals and participants and understanding the qualitative impact, really. But I think we have to have the conversation, because we're obviously moving that way in terms of identifying people earlier in the disease trajectory. We're moving that way with treatments. And most patients want, obviously, to see that shift. But it does mean we're going to be collecting data earlier, and we're going to probably be sharing that information. So we've got to understand how people want that communicated. And what they do about it, if they need further support, that's a whole other concern as well.
Okay, many thanks, and many thanks to the panel. One more round of applause for everybody.